QpQs and PVR calculations. This is a talk that I have done before, so some of you might already be familiar with some of the stuff that we're going to discuss, but I think this is a very important topic, and there is no harm done in going through things and revising things again. Okay, so let us hope that the slide thing works. Fantastic. So now I think the first thing we need to know is when do we do these calculations? When is it indicated to calculate QpQs and PVR? Now, this, I mean, one should bear in mind that hemodynamic calculations are not perfect. Okay, there is a lot of room for error. So it is not a a miraculous solution to all your questions about operability. So when you set out to do the hemodynamic study, you should clearly know in your mind that the indications for that study, okay, and carry the cath study out only if there is a clear indication. Otherwise, you could well end up confusing yourself and creating more problems than you solve. Okay. So the main indication for carrying out a hemodynamic study is in borderline situations. Okay, so now often we see children in clinic where either there are clear signs of a left to right shunt with respiratory distress, with a big left atrium and left ventricle, increased pulmonary venous return, ECG signs that show high flow. All of these signs clearly indicate, and of course a big heart on chest X-ray with increased pulmonary vascularity. All of these signs indicate that the child is operable. In this situation, a hemodynamic study is perhaps not required, okay, irrespective of the age of the child. Now, on the other end of the spectrum, you have patients who are clearly inoperable, i.e. they do not have signs of increased pulmonary blood flow. They may have done when they were infants, but now they have actually reached a stage where there is pulmonary vascular disease, and some of them may even be cyanosed or clogged. So at this end of the spectrum as well, it is clear clinically that they are inoperable. So these two ends of the spectra are easy to assess, or relatively easier to assess clinically. Now it is the gray zone in between that requires close attention, careful examination and assessment, and perhaps a hemodynamic study. Okay, so this is when you would carry out a hemodynamic study. Now if you look at this slide, it is a little busy, but here again it summarizes the features that suggest operability and the features that suggest inoperability. So if we look at the history of feeding difficulty, respiratory distress, failure to thrive, all of these are suggestive that there is high pulmonary blood flow. Now if the patient gives a history that there were initial symptoms but there was subsequent improvement of the symptoms, it implies one of two things: one, pulmonary vascular disease, or two, perhaps some pulmonary stenosis that has developed either in the form of double-chambered right ventricle, or maybe there was some pulmonary valve abnormality which was not detected earlier, which has progressed. Okay, but from the history you get some information about the operability of the patient. Of course, next you have the physical examination, and you pay attention to things like the second heart sound and also presence or absence of an apical diastolic murmur, which suggests high flow across the mitral valve. Saturations are quite important, and if a patient has saturations greater than 95%, it is a reassuring sign. So when you have sats in the low 90s or sub 90s, then that is a fairly strong clue in the absence of respiratory pathology that perhaps this patient is inoperable. Again, chest X-ray and ECG are adjuvant aids. Chest X-ray showing cardiomegaly, increased pulmonary vascularity. All of this suggests operability, whereas if you have a heart that is not as enlarged as you would expect, where the main pulmonary artery may be dilated, but distally the pulmonary vasculature is not prominent, i.e. peripheral pruning, then it is suggestive of inoperability. So again, ECG showing right ventricular dominance and absence of Q waves in the left lateral lead is an ominous sign and suggests that the patient perhaps has pulmonary vascular disease. So these are some of the clues that we can use for assessment. And as I mentioned earlier, majority of the patients can probably be assessed just clinically and with an X-ray and ECG. It is only a small minority that should be put forward for cardiac catheterization. Sorry. Right. So this is an example of chest X-ray, similar to what we were discussing. So here you see on the right-hand side a child who's got some kyphoscoliosis and some chest sort of chest wall abnormalities, but you can see his heart is clearly enlarged, this child is actually 17 years of age. So both the X-rays are from similarly aged patients. However, you can see that there is a clear difference in the appearance of the X-ray. So age itself does not preclude treatment. Okay, so this is important to bear in mind, and I think it is important to assess each patient, irrespective of his age, you know, as an individual, on an individual case-to-case basis, before we write them off and you know, say condemn them to only medical management. Okay. Before we start out on any QpQs or PVR calculations, we have to make ourselves familiar with what is known as Fick's Principle. Now, this is the principle on which the whole of the hemodynamic calculation in the cath lab is based. It is a fairly simple principle and just requires you know, understanding of the basic concepts. So, if you consider oxygen to be the marker, okay, it's called an indicator or a marker, then and you consider the body to be this, say, this rectangle. So, or the body or the organs to be this rectangle. Now, arterial blood carries oxygen to all the organs. In the organs, oxygen is consumed. Some of the oxygen which is not consumed comes out in the venous blood. Okay. Now, if you knew the amount of oxygen in the arterial blood, the amount of oxygen in the venous blood, and what the normal consumption of oxygen by the body is in, you know, in terms of time, ml per minute, you know, how much oxygen does the body consume every minute? If you knew that, then you can calculate how much blood is flowing through the body every minute. Okay. So just spend a couple of minutes on this, just understanding the concept. So if you knew the concentration of oxygen in the arterial side and the concentration of oxygen on the venous side, and you also knew every minute how much oxygen is consumed by the body, then you can figure out how much blood is actually flowing through the body per minute. Okay, and this principle is used to calculate cardiac output. Now, in a patient who does not have a shunt, your cardiac output is the same as systemic output is the same as pulmonary blood flow. Okay, so systemic blood flow and pulmonary blood flow are equal in the absence of a shunt, and that equals the cardiac output. Okay, excuse me, sorry. Right, so now this illustration is just to demonstrate how oxygen consumption is can be calculated. Now, in the ideal world, we want to calculate the oxygen consumption, okay, on a case-to-case basis. But you can see how practically impossible it is. You need an airtight chamber into which the patient breathes in and out, so that you then know the concentration of oxygen in the inspired air. You calculate the concentration of oxygen in the expired air, and then you figure out how much oxygen the patient is consuming per minute. Okay, but in practical terms, this is not possible, particularly in our pediatric patients. So there are tables available, and I'll show you the tables in a couple of slides, which give you the oxygen consumption for a particular age, for a particular sex, and at a certain heart rate. So these are the main variables that affect oxygen consumption. So it's the age, the sex, and the heart rate. So we have some broad tables that will help us, and this has to be indexed to body surface area. Okay, so important thing is to always make sure you have a height and a weight on the patient. Make sure that you take a baseline heart rate so you know what the heart rate is, and these you use in order to calculate the body surface area, so you can index the VO2, and also you use the age, the heart rate, and the sex to figure out what the VO2 consumption is from the tables. But remember that VO2 itself, the very basis of hemodynamic calculation, oxygen consumption, is an assumption. Okay, it is not a real measurement. It is an assumption from a table. Now, this table of values was obtained from healthy volunteers, and so really, how far we can extrapolate these values to various pathological states, we don't really know. However, this is the best that we have, and this is what we can use. So, like I said initially, hemodynamic calculations are prone to error, okay, and they are not a miraculous answer to all your questions regarding operability. Okay, so if we apply Fick's principle, okay, and we say and we want to calculate cardiac output. So cardiac output, which is in liters per minute, okay. We have looking back at the the previous slides, we said that flow equals oxygen consumption here. Oh, sorry. Oxygen consumption by difference in oxygen content between the artery and the vein. Okay. If you apply the same principle, the cardiac output, which is the flow, equals oxygen consumption, which is in ml per minute, divided by oxygen content in arterial blood minus oxygen content in venous blood. Okay. So direct application of that formula. Now, how do you calculate oxygen content? What is oxygen content? So it involves hemoglobin. So hemoglobin carries majority of oxygen in blood, particularly in room air. Okay, you times that by 1.36. So what is this 1.36? 1.36 is the number of ml of oxygen that binds with 1 gram of hemoglobin. So if you want to know how much total oxygen is carried by all the hemoglobin in the body, it is hemoglobin multiplied by 1.36. That will give you the amount of oxygen carried by hemoglobin. Okay, and you times that by the saturation. So how saturated is the hemoglobin? So say for example the saturation is 95%, then you times that by 95 divided by 100, or 0.95. So it's not just the oxygen saturation, it is the fractional oxygen saturation. Okay. All of this is made for the new trainees. It might be quite a lot to take in, but I suggest that you go home and have a read through some of the standard textbooks, which will again clarify the same issues. But I hope that there is some clarity, with this talk. Now, this is the amount of hemoglobin this is the amount of oxygen that is carried by hemoglobin. We all know that oxygen is carried partly bound to hemoglobin and partly dissolved. Okay. Now, in room air, the amount of dissolved oxygen is only very small, so it can be ignored. But remember, this is not the case when you give the patient 100% oxygen. So when you're doing calculations after getting the patient to breathe 100% oxygen, it is important to have the dissolved oxygen as part of your calculation, and we will go through that later on. Okay. So coming back to here, the cardiac output is the oxygen VO2, which is oxygen consumption divided by oxygen content. So you can see in the in the calculation below how this is worked out. Hemoglobin in grams per deciliter times 1.36, which is the amount of oxygen carried by each gram of hemoglobin, times times iotic sat minus PA sat times 10. Okay. So the times 10, which is down here, is because cardiac output is expressed in liters per minute, whereas VO2 is expressed in mils per minute. So we are just converting the mils per minute into liters. Okay. So this is how you calculate cardiac output. So you know the arterial saturation and you know the mixed venous saturation. In the absence of a shunt, the venous saturation and the PA saturation are the same. Okay. Mixed venous saturation and PA saturation are the same. So that is how cardiac output is calculated. Now we've already gone through this, we really don't need to go through this again. So this is the table that I was talking to you about. So you see here that it gives you age, sex, heart rate. In fact, various heart rates, the VO2 in mils per minute per meter squared is different. So remember that this is per meter squared, so you have to adjust it for the body surface area of the patient. Okay, so that is why it is important to get height, weight, and then calculate body surface area. And supposing the body surface area, is 0.8, then you have to adjust it for the body surface area. Okay. Now, like we mentioned before, in the absence of a shunt, QP, QS, and cardiac output are all equal. Okay. Now, if you look at QP or the pulmonary circulation, you apply the same formula again. You have, VO2, which is the oxygen consumption. Bottom, the denominator, you have hemoglobin times 1.36 times 10, which is the conversion factor, times the oxygen in the arterial side, which is the pulmonary venous side here, and on the venous side, minus the oxygen content in the venous side. So that is the pulmonary artery side. Okay, PV sat minus PA sat. Remember, this has to be fractional saturation. Okay, so for example, if your PV sat is 99 and your PA sat is say 80, it will be 19 divided by 100, so it will be 0.19. So remember that you have to express it as a fraction. Similarly, QS, you follow the formula that is outlined below. Now, mixed venous saturation. What do we mean by mixed venous saturation? So for QS calculation, you see you need to use MV-sat or mixed venous sat. So mixed venous saturation can be calculated in a variety of ways. Now, in very small babies, we take mixed venous saturation to be 3 times SVC sat plus 1 time IVC sat, the whole thing divided by 4. So you take an average of the SVC and IVC sat. Now, the concept is that in smaller babies, the SVC contributes more to the venous circulation than the IVC. And as the child gets bigger, the SVC contribution becomes smaller. So if you see in older children, it is only twice SVC sat plus once IVC sat divided by 3. Okay. Now, IVC saturations are notoriously prone to error. This is because you have, depending on the position of the catheter, you may be very close to the hepatic vein, you may be very close to the renal vein, and you don't know how far your side holes in the catheter are from the from these renal and hepatic vessels. So renal venous blood is rich in oxygen, hepatic venous blood is quite desaturated, so you could get a very false value from IVC sample. So although yes, people do take an IVC sample, some people just say, look, I cannot be bothered with this whole IVC sampling because it is so prone to error, and they end up taking only an SVC sample for saturation. Okay, and they use that as a mixed venous saturation. I mean, okay, you can take an RA sat, but once again you have the same issue. Where do you take the RA sat from? High RA, you have SVC blood. Low RA, you have IVC blood. Then you could have coronary sinus blood coming in, which is extremely desaturated. You can have an ASD, which confuses the situation further. So you've got to be careful about where you sample. Okay, so going back to your original point, hemodynamic calculations are prone to error, and they are not the miracle solution to all your operability questions. So when you have a left to right shunt, if you want to know, what is the left to right flow or Q, okay? Basically, when you have a left to right shunt, the pulmonary blood flow is greater than the systemic blood flow, right? So this is because systemic blood flows into pulmonary circulation, and you have a formula to calculate how much what is the quantity of this left to right shunt. Okay, what we are normally interested in is the QP by QS ratio, okay, which tells you how much more blood is flowing into the pulmonary circulation as compared to the systemic circulation. Now we know how to calculate QP. We've gone through that previously. We know how to calculate QS, and if you just divide QP by QS, okay, you get your QP by QS ratio. Now, if you notice, a lot of these factors are common, so they can actually be cancelled out mathematically. So you can simplify this QP by QS equation very easily into aortic sat minus mixed venous sat divided by pulmonary venous sat minus PA sat. So this is something that you can do mentally, just at the time when you are cathing the patient and you have the values of saturations at hand, you can very quickly calculate this QP by QS ratio without any problems. Now there is a concept called QET, which is the effective pulmonary blood flow. So exactly what is meant by effective pulmonary blood flow? Now venous blood or desaturated blood goes to the lungs and picks up oxygen. Okay. Now when you have, for example, a left to right shunt, okay, the left to right shunt blood is actually not desaturated. So it is, although it goes to the lungs, it is not going for any useful purpose. You understand? So this left to right shunt is an additional non-effective part of the QP. So the QEP or Q effective pulmonary blood flow is actually the portion of pulmonary blood flow that actually gets oxygenated in the lungs. So you can see that the left to right shunt is QP minus QEP. So QP is the total pulmonary blood flow. Say in the presence of a left to right shunt, the total pulmonary blood flow minus the QEP is actually the portion that requires to be oxygenated. The rest of it is what is your ineffective left to right shunt. Okay. Now just as an aside or an additional slide, I would just like to make a point about admixture physiology. Okay, for example, single ventricle type scenarios, or where you have what we call complete mixing scenarios. Now here the systemic saturation is a good guide to QPQS. So depending on your arterial sat, you can guesstimate, you can guess what the QPQS will be even without doing a hemodynamic study. Okay. So for example, if you have an arterial saturation of say 85%, then normally, assuming the patient has normal cardiac output, the mixed venous sat will at least be 60%. Okay. So here, if you calculate QPQS, you know that QP by QS is aortic sat minus SVC sat divided by pulmonary venous sat minus PA sat. Because it is common mixing type physiology, aortic sat and pulmonary artery sat will be the same. Agreed? So the QPQS calculation can be simply worked out if you assume the mixed venous saturation to be 60 and you assume the pulmonary venous saturation to be 100, then you get an idea as to what the QPQS is. Of course, if the mixed venous sat is slightly higher at 70, then the QPQS value varies slightly. But then you get a broad idea. So if the arterial sat is 90%, QPQS is high, either 2 or 3:1. If it is 95%, it's extremely high, 5 or 7:1. So the arterial sat will give you a guide in this sort of common mixing type physiology. It will give you a fairly reasonable guide as to what the QPQS in this patient is. Okay. So even without sort of doing a cath. Right. So before we go on to resistances, I'm just going to ask if any of you have any doubts or any clarifications. I think this talk is quite heavy on formulae and calculations. So if there's anything that you want to ask me about, please feel free to ask me now. I'll give you a minute or two to just interact with me. Anything at all that you want to ask about? Okay. So I'll assume you're happy so far. Now let us go on and look at vascular resistances. Now resistance in any circuit is defined as the difference in pressure between the two ends of the circuit divided by the flow. So if you use this formula and look at pulmonary vascular resistance, it is the difference in pressure between the two ends. So one end is the PA pressure, other end is the LA pressure. So mean PA pressure minus mean LA pressure divided by the flow, which you know already from your calculation to be QP. So this is your pulmonary vascular resistance. Similarly, systemic vascular resistance. So one end is the mean aortic pressure, other end is the mean RA pressure. So you're talking about the systemic bed of capillaries and so on. So the other end is the mean RA pressure or the venous pressure. divided by QS. Okay, and these are usually indexed for body surface area. Now, if you what I would suggest is that you initially index the VO2 max, and then everything becomes indexed after that. Okay, so sorry, right. Now, right from the outset, I have been cautioning you about various errors that are possible in flow and resistance calculations. I think we often ignore these. We ignore this, the fact that hemodynamic calculations are prone to errors, and one has to be, if you decide to embark on a hemodynamic study, you have to be meticulous in the way you carry it out. Okay. Now, this starts from the moment you come into the lab, you position your patient, you make sure that there is no airway obstruction. Okay, you don't overly sedate the patient. Why not? Because then they could have respiratory depression, their CO2 could go up, they can become acidotic, and they can falsely give you, high PA pressures and low saturation values. Okay, so you have to make sure that the patient is as awake as possible for you to carry out the test and is actually breathing normally. At baseline, I would suggest you do an ABG. This is again to confirm normal acid base and normocapnia. Okay, I have known cases where this was in an intubated patient and where the tube has gone down one lung and one lung is totally collapsed. And when you take an ABG, you notice that the ABG is grossly abnormal. So if your PA pressure is high at that point, it means nothing. So you have to make sure that the respiratory status of the patient is as stable as you can get it to be. Okay. The next thing, of course, is your zeroing of equipment. Always make sure you spend the time to zero equipment properly. Now, once you think that you have achieved good zeroing during the course of the cath, make sure that when you enter the ventricle, you check your zero. So look at the the lowest diastolic dip of your ventricular trace. That should correspond with the zero. So if it goes much further down than the zero, then there is a flaw in the zeroing, and you need to re-zero so that you get your early diastolic pressure, which should be zero, at zero level. Okay, so you have to make sure that you do everything you can to optimize your setting. Now, there are errors that can happen. There can be sampling errors, like we talked about how you can have IDC sampling errors. Sometimes you can do something about it. Sometimes it's just the way the blood flows. So you then have to make a call: do we include the IVC or just use the SVC saturation? Again, remember that pulmonary veins, each pulmonary vein can actually have a different saturation. Say you have some sort of pulmonary pathology, that can be patchy atelectasis or patchy changes. Each pulmonary vein could have a different saturation, so it complicates matters even further. However, routinely, when you have a normal gas and there are no obvious pulmonary parenchymal issues, most people take one or at the most two pulmonary venous samples. Okay, that is if your atrial septum is open and it allows you to take the pulmonary venous sample. Otherwise, often pulmonary venous saturation is assumed, and you assume it to be 99 or 100, on the basis that there is no obvious pulmonary pathology. Okay. Now, you can, when you're taking pulmonary artery saturations, make sure that the catheter is not wedged. Otherwise, you'll be sampling much more oxygenated blood. So all these sampling errors can happen. Then make sure that the sample is not diluted. It should be, you shouldn't have flush along with it. You should take a good discard and then take your sample. Then make sure there isn't an air bubble in the syringe. If there is an air bubble, make sure you remove the air bubble before you actually analyze. Now, in the ideal world, actually, as you take each sample, it has to be measured. And really, the best way of taking saturations for hemodynamic calculation is to use that saturation measuring apparatus, which you can keep in the lab. This is not an ABG. Okay, this is like photospectrometry. You put the sample in, it gives you a saturation. That's it. That is the best way to do it. Because in an ABG, the saturation is actually sort of calculated from a lot of the other factors in the ABG. So the better way of doing it is actually using a direct saturation measurement equipment. However, we work in a setup where that may not be available, so we have to rely on the ABG. Okay, so ideally, like I said, as you take samples, you should get results back. Okay, so there is no delay and no degradation of the sample. That is one reason. The other is, if you get a false value, say for example, you're taking an SVC sample and you're getting a value of 99 or 100, and you're thinking, this is not right. Okay, so then you may have to retake the sample. Whereas if you send all your blood gas samples and you then finish your procedure and come out, and then later you realize that your values are all faulty, you can do nothing about it at that point. So you should try and ensure that your samples go off and you get at least the baseline results. Forget the oxygen results, at least the baseline results you should have, so that you have some valid data to carry out your calculations based on. Of course, we assume a lot of things, you know about that, and so on. So these are the main issues that confound your calculations in the lab. Now, another important point, very important, I see a lot of people do this, is that failure to account for dissolved oxygen. Okay, so like we discussed, in baseline status, the amount of dissolved oxygen is only minimal. So it doesn't really need to be accounted for. It doesn't make a big difference. However, when you give 100% oxygen, this amount of dissolved oxygen is a huge part of the oxygen content. So if you fail to account for it, what happens is that you get a very optimistic QpQs, an optimistic PVRI. It underestimates the PVRI. So it gives you a false impression of operability. Okay, and really frankly, this can be disastrous for the patient. So it is very important to account for the dissolved oxygen. The other point I'd like to make is, now how do you give this 100% oxygen? A lot of labs, I have noticed, do not have a rebreathing bag. So if you just give face mask oxygen, okay, without a rebreathing bag, you can only give 30 to 40% oxygen to the patient. Most of the oxygen, however much you turn it up, it all goes into the atmosphere. So I think in the ideal situation, actually, I'm sure the rebreathing bag, one rebreathing bag does not cost that much. So what we should do if we are carrying out hemodynamic calculations in the lab is at least have one mask, one rebreathing bag attachment thing, so that for these particular patients we can attach a rebreathing bag and we can actually deliver 100% oxygen. Okay, these are small things which we sometimes overlook, and these are important. Okay, right. Now, we've already gone through lots of this stuff, but let's just quickly run through it. We talked about pressure monitoring, no bubbles in the circuit, confirming your zero. In terms of the catheter choice, usually there is a recommendation to use an end-hole catheter so you can wedge it and so on. Now, I have found sometimes that the end-hole catheter gets too wedged. Tissue gets into the single hole in the catheter and actually makes it difficult for you to get measurements. So if you're having such problems, then maybe you should use an end hole plus closely spaced side holes type catheter, so that you don't have this issue of sort of over wedging and damping of the trace. Okay, right. So ensure that the patient is adequately ventilated. Check an arterial blood gas. Then you have to try and carry out the measurements in a short space of time. Remember that the patient is in a certain physiological state. Now, if the time lag between you taking the first sample and the last sample in one batch is say half an hour, then in that half an hour, a lot of things could have changed. So you should aim to carry out all the measurements rapidly. Okay, so the general dictum is you get to the most difficult part in the heart, i.e. say you want to do just a baseline assessment. You're not doing anything else, you're just doing a baseline assessment. Then you enter the PA first. Okay, because that might be the most difficult to get into. You get the measurement. Then on your way out, you get the SVC and all the other easier, simpler measurements. Okay. What we do tend to do in practice is, because often we do an oxygen study and we leave the catheter in the pulmonary artery during that process. So what I tend to do in those situations is I get the venous measurement on my way in and make sure I get into the PA quickly, and then get the baseline measurements done, then give oxygen, and then on the way out, I keep the catheter in the PA. On the way out, I come back from PA to the say SVC or whatever. So, but the basic idea is that you try and get all the measurements done within a short space of time in rapid succession. Okay. Other very important thing is always obtain hemodynamic data before injecting contrast. I know that in some units perhaps they do an SVC shot before they proceed. I'm not personally in favor of it. I mean, I personally would prefer to do all the hemodynamic stuff before even giving a hand injection. Of course, one has to be pragmatic, but I think it is important to get clean hemodynamic data, and there is no point, in my opinion, carrying out a half-hearted or an imperfect hemodynamics study. Okay, so that's that. Right, next we go on to reversibility testing. See, baseline data is very important, and I think baseline data gives you much more information than any other sort of fancy testing that you might do in the lab. Now, one of the problems with things like 100% oxygen, now like we discussed, are we really delivering 100% oxygen? Okay. Now, in addition, we assume a lot of things. This oxygen consumption assumption and so on, oxygen content assumption. They're all assumptions. They're all calculations. They're all prone to error. All of this becomes inaccurate. The inaccuracies or the errors become much more pronounced in 100% oxygen as compared to room air. Also, a lot of the time people forget to include dissolved oxygen. So one has to be careful in the use of reversibility testing. Reversibility testing obviously has been traditionally used for assessment of response to say something like antipulmonary hypertensive therapy. But I think a clear link between reversibility testing and outcomes, in isolation, has not been established. So we have to remember that. The other thing, of course, is nitric. Once again, data on the relationship between response to nitric and long-term outcomes is not available. Okay, so all we have is there is some data which links response to nitric with early post-op pulmonary hypertension, which is fine. But actually, that is a totally different, issue. Early post-op pulmonary hypertension. What we are interested in is, are we worsening the long-term outcome of this patient by carrying out this procedure? And nitric testing does not really, or has not been shown to give us any further answers to this question. Okay, so I think, although yes, it is perhaps there is some additional information that you gain from reversibility testing, I'm not sure that its value has been totally proven yet. Okay. So just to illustrate, you remember I told you about oxygen content. So here you see, when you are giving 100% oxygen, you not only use the oxygen that is bound to hemoglobin, but you also use the dissolved oxygen. So that you get from the gas, and you have to multiply it by a factor of 0.003. Okay. So when you, and then you add the two bits of oxygen up, and that gives you the total oxygen content. So actually, I think what you need to do is do this 0.003 times FiO2 calculation for pulmonary vein and pulmonary artery. So this formula needs minor modification, which is, I should have put out here. I should have 0.003 times FiO2 of the PV of the pulmonary vein minus 0.003 times FiO2 of the pulmonary artery. Okay, I hope this is clear. What I will do is I will clarify this. I'll write this formula out accurately, and I'll email each of you so that there is no confusion. But what I'm trying to say is that the oxygen content difference between pulmonary vein and pulmonary artery should be accounted for. Okay, so there should be sort of a little bracket here which says pulmonary vein, FiO2 of the pulmonary vein minus FiO2 of the pulmonary artery. Then you add the two oxygen fractions together, and then you calculate. And that gives you the accurate QP with 100% oxygen. Just a few minutes on a few other things that can be done. Okay. Now, more recently, some literature was published from Amrita Institute on the value of arterial blood gas assessment post-exercise, and they found that if you did this, was taking a cohort of ASD patients with pulmonary hypertension, that in borderline operability cases, when they exercise the patient, a fall in saturation on exercise was a poor prognostic factor, and if there was a fall of more than 10%, it indicated that the PVRI, when they then cathed the patient, the PVRI was greater than 7, I think. So I think this would be a good screening tool to decide if, say, the ABG did not show any fall and the other signs were more favorable, maybe you can take this patient for surgery without a cath. But if the ABG was unfavorable, then probably the PVR is high and you need to look at that in the lab. Now I have some case studies. Let me just look at the time. Okay, we have another 15-20 minutes. So we have some case studies here, which basically the whole point of the case studies is to highlight the the importance of following a comprehensive approach. So just a cath and just hemodynamics, say if you don't examine the patient, you don't do an ECG, you don't do an X-ray, and you just do a cath, the information you get from the cath is 0. Okay, there's no point doing a cath like that. Now you need to have assessed the patient carefully prior to the cath, and like I said, a lot of patients will not require a cath. Okay, just clinical assessment will give you enough information to tell you whether this patient is operable or inoperable. It is only in borderline or gray cases that you have to carry out a cath. Okay, but again, your initial assessment is very important. So here you have patient 1, who is a 13-year-old male, so quite old, who was detected to have congenital heart disease early in life but was not treated. So he is presented now for evaluation and surgery. His baseline saturations are slightly variable. I mean, this is the problem practically that we sometimes face. Either because of physiological variability, sometimes because probes are not compatible to children, or the equipment is slightly faulty. So it often leaves us in a bit of a confusion as to what is the real saturation of this child. Okay, but you see that there is, at times the saturation has been measured to be 92, which is a little bit on the lower side. He does not have an MDM. Now this MDM is something that if you're a practiced clinician, if you're an experienced clinician, you're able to detect these diastolic flow murmurs, and they are believed to have a good correlation with operability. I must confess honestly that sometimes I find it difficult to detect MDMs, and maybe in that situation, you try and exercise the patient, whatever, you do all the maneuvers required to elicit the MDM, but the MDM is one of the clinical signs that you look for. Again, you listen to the second heart sound. Is it of the patient here? This patient had a palpable and loud second heart sound. Now his ECG showed a poor R wave progression and right ventricular hypertrophy and right axis deviation. This was his X-ray. Okay, so what do you guys think about this X-ray? Can I have some sort of input? I think I've been talking for too long now. Any comments on the X-ray? Excellent. Okay. So yeah, I mean, yes, definitely the pulmonary artery is prominent. There's no doubt about it. Okay, and the degree of cardiomegaly probably not as much. So yeah, very borderline X-ray, not very encouraging. So although this main pulmonary artery area looks prominent, peripherally, if you look particularly on the on the left side, you don't see much vasculature. So and look at it distally, you can't see the vascularity seems to sort of stop here. So yes, so the X-ray is not very encouraging. Now the echocardiogram shows actually double outlet right ventricle type anatomy. However, it's a rootable sort of VSD, and there is, let me just get that down. This is meant to play. Yes, fantastic. So it appears rootable, and the flow across it was, there is a degree of biotic override, and the flow was bidirectional. Okay. Well, what is your impression regarding this, regarding the operability in this patient? What do you think? Do you think this patient, from your clinical assessment and ECG and X-ray, do you think this patient is operable or not? So we feel that looking at the X-ray, that it is more suggestive of inoperability. Again, the ECG is not that, optimistic. So his right axis deviation, right ventricular hypertrophy, poor R wave progression, all of that fits in with probably a pulmonary hypertensive patient. He does not have an MDM. His saturations, again, they're slightly confusing. So at times they were 92, at times they were 96, so probably slightly borderline on that count. So a little borderline. So we, it was decided that we would cath this patient. Okay, so this is the cath data. So just look at the baseline data first. Okay, so if you look at the baseline data, you see that there is not that much of a step up between the SVC sat and the PA sat. Okay, you see that the PA mean pressure is systemic, as you would expect. Even with giving oxygen, again, that there is no increase in the step up between the SVC sat and the PA sat. Again, if you look at the baseline saturations now on the cath table, only 92%. Okay, so if we then go on to calculate QpQs and PVRI and SVRI, we can do it in air and in 100% oxygen. So remember that it has to be done at a particular heart rate. So we assume that the heart rate of this patient was 100 during the procedure, and I will show you the results. I mean, I think it's a good exercise to take these numbers and to actually crunch them yourself. But if you look at the QP calculation and the PVRI calculation, I've worked it out here just to illustrate how it should be done. You see that the PVRI is nearly 13, clearly inoperable. So at this sort of PVRI, one wouldn't be doing anything to this patient, would probably be giving the patient medical therapy. Okay, so here you have the PVRI both in air and in oxygen, and you see that it is pretty high, and there is no response really to oxygen inhalation. Now, if you look at the exercise test of the same patient, you see that his baseline sat at the time of the exercise test was 98%. Post exercise it drops to 91%. So again, fits in with sort of inoperability. Okay. So in terms of decision making, he had unfavorable clinical signs. He had unfavorable ABG and unfavorable hemodynamic data. So the decision here was to medically manage the patient. So this is patient 1. Now we have another patient, okay, 6-year-old, large VSD, again late presentation and presented for evaluation for surgery. Now this chap had some chest deformity. Okay, remember the X-ray that we saw earlier on with the kyphoscoliosis? It's actually this patient's X-ray. So he had some chest deformity and quite changeable clinical signs. So at times, he had an MDM. Sometimes we could not pick up the MDM. His saturations were only 91%. But one thing with the saturations was that when we gave him oxygen, okay, this is just just normal face mask oxygen, his stats actually picked up. So this implied to us that there was probably a respiratory component to the whole problem. But even in this setting, it is difficult. Say this patient has chest deformity and has low saturations. You give some oxygen and the saturations pick up. So I suppose you can come to the conclusion that the low sats are not due to pulmonary hypertension, they are due to the respiratory pathology. However, if there is respiratory pathology, it does put the patient at a higher risk of pulmonary hypertension. So the long-term outcome is still uncertain. In a patient like this, you may say, okay, the stats have improved with oxygen, but are you going to give him oxygen 24 hours of the day, 7 days of the week? No. So then you are in a little bit, because at the end of the day, it is not just working out whether the cause is respiratory or cardiac. It is also, real life. So in real life, what is going to happen to this patient? So you in the presence of respiratory or chest wall problems, you do have to take that into consideration when you're making a management decision. So anyway, going back to this guy, he had a loud P2, and his ECG again showed poor progression of R waves, tall R in D5, D6, tall R waves in V1, V4. So basically, right ventricular hypertrophy, signs of right ventricular hypertrophy. And this is his X-ray. So comments on the X-ray, on this X-ray? What do you think? Any comments on this X-ray? Is there cardiomegaly? Okay. Yeah. So actually, compared to the previous patient, the vascularity looks a bit more promising. You know, you can see increased vascularity out into the peripheries. There is some mild cardiomegaly, okay, and there is some RA enlargement. So perhaps a little bit more promising. You can see that there is kyphoscoliosis and deformity of the chest. So the echo, just try and see if it works. So you can see here that there is a VSE with bidirectional flow. Okay, sorry, the scale setting and the gain setting is a bit poor. Let me try and move this on to the next slide. Okay, so what is your impression regarding operability in this patient, and what will you do next? So right now we have done a clinical assessment. We have an ECG and a chest X-ray, and we have this echo. So from this information, what is your assessment of this patient? Is the patient operable? Is the patient inoperable? Can you make that decision? And what are the factors favoring operability in this patient? Looks operable. Okay. Now, like in the previous patient, we discussed the role of ABG. So, you know, one of the things is maybe before a cath, an ABG here would be a useful thing. Okay. So, if an ABG is done at baseline and then maybe ABG after exercise, also you can check the gas or saturation after just giving oxygen to this patient. So that is what was done. Okay. And of course, as the next thing, a cath. Now, before coming to the cath, oops, right. So I'll tell you what the exercise ABG showed here. So pre-exercise, his stats were actually 97%. He got exercised, his stats did not drop. So that is the key thing. Okay, he did not drop. That was a positive factor. And when he was given oxygen, his stats went up to nearly 100%. So overall, this ABG data looks pretty promising to me. Okay. So now let's just go back to the cath. Right. So we took this patient up for cath, right? So all of these things were done, samples were taken, patient was taken off the table. And then we got these results back. So what do you think of these results? Good results? Bad results? What do you think of these results? Baseline aortic saturation is 92%, which is not fantastic, but okay. But remember, he was in the lab, he's a 6-year-old, he had some sedation, he has some lung pathology, so perhaps related to that. So if you look at the baseline data, what do you find strange about it? Which perhaps you don't expect. Answers? Correct. So the pulmonary artery saturation is actually correct. So, you know, instantly you're thinking there is something not totally right here. Then you look at the sats in O2. Now you get a series of saturations which all look very unreliable. Right now, if this patient has come off the table, you've got these values. So what is the point in carrying out this test? Not much. So after having done this cath, you're not any wiser. So then you have a choice between saying, forget the cath results, let me just go with clinical impression and just operate on this child, okay. But then you are a little worried, okay, you've got an ABG which is reassuring, but his baseline SAFs are not high, okay, they're often in the low 90s, so it's a little bit of a worrisome situation. Although it may be respiratory related, it takes courage to go ahead and operate on this child without knowing, without having some decent hemodynamic data. So a decision was made to repeat the cath, okay, and this was the repeat cath result. Now this looks much more reassuring. At this time it was decided that we wouldn't do the oxygen testing, we'll just do a baseline study and we'll see what the baseline study shows. Now here you see there is a very good step up between the FVC and the PA, and okay, aortic paths are a little bit on the lower side, but overall this data to me suggests operability. So when PVRI was done, it was around QpQs was 2, PVRI was 11. So still a little bit high actually. So because the PA pressure, mean PA pressure was high, but the QpQs was 2. So and your X-ray findings suggested operability, your arterial blood gas suggested operability. So what would you do in this setting? Your PVRI is high actually, 11. So maybe some people would say, this is too high, don't operate. What would you do in this setting? What would you do? I'm trying to find the chat box here. Sorry. I don't know where it is. I'm having some difficulty getting the chat box to work for me. It's really pretty strange. Okay, now we got it. Fantastic. Okay, right. So I've got post O2 with O2 may be reversible. Okay, right. I see what you mean. Yeah. So anyway, I think a decision was made that yes, this child was probably a high risk candidate, but that he deserved a chance in terms of surgery. Okay, so that's what was done. VSD patch, one of those flat, fenestrated VSD patches was put in, and at the time of discharge, he had small residual apical VSDs. He had a RV systolic pressure of 50 plus RA, which is not great, and he was discharged home on antipulmonary hypertensives. The long-term outcome is still uncertain in this child, okay? And like I mentioned before, that the fact that there is respiratory pathology means that could contribute to pulmonary hypertension. So forget the cardiovascular aspect of it. There is also a respiratory aspect to the pulmonary hypertension. So I don't know what will come of this child in later life, whether we have actually altered his prognosis favorably or whether we have done him a disservice. Now he does have some residual VSDs or some residual flow, which is a good thing. The other thing people do is leave an ASD so that at least there is some egress for the right ventricle. If his pulmonary hypertension progresses, at least we haven't worsened his long-term prognosis by completely sealing off the ASD and the VSD and everything. So the other option is to leave an ASD open. But I think this child, we don't know, the future is uncertain. Okay, and this is the last patient, 12-year-old, similar sort of story, large VSD, evaluated. He was initially symptomatic, but subsequently he has improved, his symptoms have improved, and that is usually a warning sign, okay? But he does have an apical MDM, and although he has a loud P2, he does have an MDM. This is his X-ray. It shows cardiomegaly. The X-ray is of a slightly poor quality, I'm afraid. I mean, there appears to be vascularity out into the peripheries. This is echo. It is not the best clip, I'm sorry, but you can see that there is some LA-LV dilatation. There is increased, quite generous pulmonary venous blood flow, and there is some LA-LV dilatation. Okay, this is probably slightly better. Bidirectional flow across the VSD, predominantly left to right. So, overall, what is your impression regarding operability in this patient? And what will you do next? I'm just trying to see if I gave you a saturation for this patient. No, I should have done. But anyway, what is your overall impression of the operability of this patient? Here again, LV looks dilated to me. Okay, I think one of you said borderline cath. Yeah, I mean it is borderline. He's an older child, and of course he's got an MDM. I think overall, clinically, my hunch is probably operable. However, we need to have a look. Okay, now let me just. So what will you do next? Two things. One, you have to do an exercise ABG because we think that it's a good tool, and also cardiac cath. So this is his cath data. This was his baseline cath data. And at that time in the unit that I was working in, we were sort of moving away from oxygen testing because of the reasons that I mentioned to you earlier, i.e. it is highly error prone, okay? Lot more errors with 100% oxygen testing than with baseline hemodynamic assessment. So here only a baseline hemodynamic assessment was done. There is a bit of a step up between SVC and PA. And when QpQs and PVR were calculated, they were not too bad. Compared to the previous patient, the PVRI is much better. 1.7 QpQs and PVRI of 8. Okay, again, if you look at it, it is a slightly borderline PVR, but it's not terrible. Then if you look at his pre and post exercise ABG, again, more reassuring. So pre-exercise 93% saturation and post-exercise 96%. So again, that would favor operability. So the child underwent VSD patch closure again with a fenestration, and on follow-up we found that his right ventricular systolic pressure had dropped down quite nicely, and he was no longer, all he had was mild pulmonary hypertension. So in this instance, it worked well. But as you can see from these three cases, decision making is extremely difficult in these patients. And the cath, although it adds some information and gives us some guide, it does not, it does not answer all our questions, and sometimes we are left with the same sort of dilemma even after the cath as we were before the cath. Okay, so I think the message that I want to give you from this talk is that an overall assessment of the patient is important. A comprehensive assessment. Just looking at one factor is not enough, and often clinical assessment with ECG, X-ray, and the baseline saturation, perhaps supplemented by ABG measurements pre and post exercise. This can give you a fairly good idea even prior to cath as to whether a patient is operable or not. Also, it will guide you as to whether you need to cath the patient or not. Okay, but you see, these are all borderline cases. Now, there are a number of patients who have come and gone without having a cath, just purely based on a comprehensive assessment of the patient's overall status. Okay, so I think that sort of brings me to the end of my talk. So I'll take questions now. Just a sec. Let me just check. Yeah, no more slides. So that brings me to the end of the talk. I noticed that there was a question somewhere in between which I missed. Yes, I mean, pulmonary venous stats can be useful to assess respiratory causes, but often what is the problem? The atrial septum is intact, okay? Then you're left in a situation where what do? Either you do a atrial septal puncture, which is high risk, or you have to try and go retrograde from the aorta, LV, back to the LA and into the pulmonary veins. Which can be quite an involved process. So I think you have to take a call. Of course, if there is an ASD, then yes, definitely, particularly in that second patient with respiratory pathology, it would have been very useful to get pulmonary venous stats as well. So pulmonary venous stats are useful. Whether you're able to get pulmonary venous stats in all patients, that is the question. Okay. Any questions, anything you want clarified, you can ask now. I will send you that that formula with the oxygen content, the dissolved oxygen incorporated. I'll modify it slightly and I'll email it to either Kunika or Dr. Sangeetha Maheshwari so she can distribute it to all of you. Fine, I think we're almost at the end now. If you have no further questions, I'll say goodbye to you and hopefully we'll meet soon. Once again in one of our cyber sessions. Okay, so bye.